Okay,
Okay. We talked about food.
okay. I'm Jerry Schaaf, in case anybody didn't know. I'm very happy to welcome Dr. Ralph Caldroney to do a presentation on polypharmacy. Dr. Caldroney received degrees and training from Washington and Lee University, Medical College of Virginia, Medical College of South Carolina, and the University of Florida at Gainesville. He was on the medical teaching staff at the University of Kentucky, and then more than 25 years in private practice in Lexington, Kentucky. Also, he served more than 8 years in the Army Reserves, volunteering on September 12th, 2001, and was deployed to Germany, Iraq, and Afghanistan. He has served as the medical director of Rockbridge Area Hospice and currently serves on the boards of directors of Rockbridge Area Hospice, the Community Foundation for Rockbridge, Bath, and Allegheny, and Valley Program for Aging Services. Dr. Caldroney.
Thank you. See, that's how my wife picks me for hats. She volunteers me for all of these positions.
That's what she should do.
My training, my background is as a general internal medicine physician, which means I was an adult pediatrician, right?
Yes.
So I took care of people anywhere from their teens up until well into their 90s and sometimes even hundreds. And through the almost 40 plus years that I was doing primary care with adults, I have prescribed tens of thousands, if not hundreds of thousands of medications through the years. But over that period of time, I also began to develop a healthy respect for the potential negative effects of medications at times, emphasis at times. So that's what we'll focus in on today. So really the central message is, if you're taking a bunch of medications, be careful to begin with, and be careful in particular if you have new or additional things added to your regimen of medications. Now, this takes us back a little bit and sort of talks about the history of medications and prescribing of medications up until really into the last century. And before that, there was absolutely no regulation. There was no oversight. You could prescribe arsenic and poisons and all sorts of things, and nobody was going to question what you were doing. But beginning in the 1900s, and in particular beginning after World War II, governments internationally, and particularly the federal government, got involved in regulating medications and saying, do these things work? All right. Is the risk less than the potential benefits? And if there are risks, what risk are we aware of, and what risk should patients as well as prescribers be aware of? So fortunately, it's a much better regulated thing than it was a long time ago. Now, this may startle you a little bit because these are really sort of minimalist definitions. And I would think for many of us in our 70s, myself included, we're already on 4 or 5 medications to begin with, and especially if we include over-the-counter things, right? So the more medications, the greater the potential. Now, it's really important to emphasize that just because you take medications and just because you take a handful of medications, it's not a guarantee that you're going to have a negative effect from it. In fact, many more times than often, the positives far outweigh the negatives. But I want to plant the seed to be aware of the potential that the more medications, the more the potential for harm. Well, who's at risk? It's mainly we Medicare eligible individuals. So typically it's people 65 and above. And a caution to inject here is if you're seeing multiple providers, here I include nurse practitioners, physician's assistants, as well as physicians, that increases the risk because many times they're prescribing medications within their lane, their focus, and they're not always aware what the other person is doing. So part of the takeaway for all this is if you're seeing somebody, and especially if it's somebody you only see very intermittently, Every time you go in there, make sure you update your medication list so they're aware of what you're on. All right, the more problems you have, heart failure and lung problems and liver problems and kidney problems and diabetes and blood clots and you name it, all right? Typically, the more medications you're gonna be on, all right? Just as sort of a function of, that's how things go, all right? The more facilities you go to, you know, if you're going to Roanoke and Charlottesville and Augusta Medical and as well as Stonewall Jackson, as well as your doctors here in town, again, the more likely that you're going to be prescribed more medications. This is a big problem in long-term care facilities, all right? Is that they oftentimes end up on a multitude of medications. And part of that is that they're miserably short-staffed in so many of these places that they tend to use chemical means to control problems which might be better served by having more at the bedside care. Mental health conditions, very important because many mental health conditions, schizophrenia, bipolar, severe depression, you know, addictions, you name it. Those folks are already on 3-4 different medications just to treat their mental health conditions. So if they develop diabetes and high blood pressure and whatever, more medications that are going to be added on to things to start with. Chronic pain syndromes, many times, and even nowadays, we're trying to get away from using opiates as much as we used to, but still there are a whole bundle of folks around, trust me, right, that take opiates on a regular basis. And many times to treat their pain syndromes, it's not just opiates like morphine and codeine and fentanyl and those kinds of things, but they may be on 2 or 3 different medications that are attempting to lessen the amount of opiates that they have to take. So they're starting off at a baseline of a lot of medications to begin with. And again, they develop diabetes, high blood pressure, whatever, boom, and suddenly their shopping cart just begins to expand. Now, this is a little bit hard to understand, and I'll try my best. Statistically, we know the more medications you take, the greater there's going to be a potential, right, that the drugs are going to interact with each other in an adverse manner. Now, just because in a test tube they interact in a negative way doesn't necessarily mean within your body that is going to happen. But we also know that of those so-called 50% or 100%, right, in a significant percentage of individuals, that's going to translate into something that has a real world impact. If you're taking a blood thinner and somebody puts you on anti-inflammatory medications, it increases the potential that the blood thinner is going to get increased in terms of its effect, or you have bleeding inside your stomach and then you're on a blood thinner, boom, you know, a catastrophe can occur, right? So if you're taking a bunch of medications, just be aware, right? Now, what are some of the potential hazards of polypharmacy, all right? Well, first, for a lot of folks, it's just, you know, it's cost. So many medications nowadays, $300, $400, $500 a month, you know? Hopefully you've got insurance that covers a portion of the expense, but sometimes it doesn't. You know, you may be doling out that 20% copay, and if you got 3, 4, 5 expensive medications, you know, that's a lot of bucks. And especially when I was practicing down the street with Dr. Hamilton, we often have to have people whose only means of income in retirement was Social Security, and sometimes half their Social Security check was going for medications. So that's a valid reason. Decreased quality of life. Certainly my idea of a good time is not getting up in the morning and taking a handful of medications, right? Or to rather go out and play golf and then have beer at the end, all right, then take medications throughout the day, all right? The more medications you use typically means you're going to multiple healthcare facilities, to multiple doctors, all right? Now, there are certain absolute contraindications, all right? We talked about the opiate epidemic, but let's say you're on a chronic pain medication of one form of an opiate and you fall down and break your leg, you know, go to the emergency room. Well, the natural instinct is going to be to add an additional medication on top of that, all right? So you got to be cautious in this particular circumstance. If you happen to have that loved one who ends up in that type of situation, you want to make sure that, say, doc, you realize they're already taking codeine on a regular basis. All right, be careful. All right. And we'll talk in more detail about the adverse drug reactions. One of the things I think we have to be also conscious of is if you've had a bad problem with a medication, all right, then you tend to become mistrustful of medications in general. And again, benefits far outweigh risk with the vast majority of medications that are used nowadays, all right? But if you've had your toes burned once or twice, you may be cautious about taking that next medication, which really may have a potential for great benefit. Now, there are circumstances in which there are really measurable physical consequences. The wrong medications and the wrong combinations can kill you. And a great example of that is the overdose epidemic that we continue to have. And if you look at people who overdose, although we tend to hear of the villain being opiates and fentanyl in particular, typically when you do drug analysis on these people, they're on multiple medications. They're oftentimes on nerve medications like Xanax and Valium and Librium and things like that, or they are taking other medications that tend to increase the risk of an overdose. There's a drug called gabapentin, which is used a lot, which we now begun to recognize many years later increases the potential for a fatal overdose if taken in conjunction with opiates. All right. A decrease in mobility, and the thing I saw a fair amount in my practice were people who are on multiple medications, all right, and in particular if they were already on blood pressure medications to begin with, and then you add something in and it increases the effect of the blood pressure medications to begin with, so that someone's blood pressure may be okay when they're lying down or sitting, but when they stand up, it tends to drop. And then somebody brings them in and say, well, grandpa's just not walking around like he used to, and you sort of scratch your head, and the next thing you know, you check their blood pressure from lying to standing, it's dropping. Well, that's the reason why grandpa isn't getting around a lot. It's not just because grandpa's getting older, it may be a medication effect, right? And this translates into a whole list of things that affect the geriatric population, including falls and changes in mobility, emergency room visits. And in the worst case scenario, if it doesn't kill you, you may end up with a broken hip because you fell because your blood pressure was too low. And a broken hip can be a life-altering event, all right? And it may well change you from being a mobile, independent person to now somebody who is largely bed-bound and dependent upon others. Now, why does it happen? Why do we have an increased potential, especially as we get older, to have interactions between medications? Well, like everything else within our system, how our system handles medication changes as we get older. Many medications that we take aren't necessarily the drug that affects something within our system. It's a bigger hunk of molecule, right? And then that molecule is metabolized. It's changed within the liver in particular, and then it goes to where it acts within the body, be it the blood pressure vessels or the brain or the kidneys or whatever. But our metabolism changes. It slows in particular as we get older. Also, we tend to have changes in our kidney function because most drugs that we take by mouth in particular, the way they get eventually eliminated from the body is through the kidneys. And even though we may be passing as much urine as we did years ago, the quality of that urine and the quality of the kidneys to get rid of medications can change over time. Now, one thing, and this is important to emphasize, is we know when medications are released, they're typically studied for, good gosh, 10, 15, 20 years before they're actually hit and around in the market. And, every time they look at these kinds of drugs, they look and see what kind of side effects could be associated. Is it nausea? Is it headaches? Is it dizziness, et cetera, et cetera, et cetera. And you can typically, say, well, X number of times with this particular medication, we're going to have this particular side effect is going to occur, 5%, 10%. whatever. So it's predictable. We know that it's going to occur. If I give you enough aspirin, you're probably going to bleed excessively. If I give you too much of an anti-inflammatory medicine like Advil or Aleve or Motrin or ibuprofen, all right, you're probably going to get an upset stomach, correct? But what we can't predict are reactions amongst medications, because everybody has their own genetic makeup, everybody has their own metabolism, everybody has their own means of eliminating medications. So even a good provider can't always predict ahead of time which drugs are going to interact adversely. Now, this is important to consider. We talked about every time you see a provider, have that list in front of you of your medications. And even in the days of computers, okay, I still encourage people to have a paper copy, or at the very least, have something that you've scanned into your phone, all right? Prescription medications are obvious, right? But there are supplements. You know, can you get in trouble if you take too much vitamin C? Yeah. Can you get in trouble if you take too much vitamin D? Yeah. Now, generally, you'd have to be taking a whole bucket load of it at a time to have complications. But even though we tend to think of these things as being relatively benign and innocuous because they're available over the counter without a prescription, too much of most anything has the potential for causing problems. Herbal agents, right? Ginkgo biloba, remember that? You know, what, 15, 20 years ago, that was going to be the new cure for depression. Well, we now begun to recognize that it interacts with a bunch of different medications. But again, if it doesn't show up on your list of things that you're taking, all right, then those people who are prescribing either pre-existing medications or new medications are not going to be aware of this. All right, so the key there is, if it's anything that you're taking on a regular basis or even on an intermittent basis, all right, make sure you report it to the people who are going to be prescribing for you. So when I go to see my doctor, I let them know I take Tylenol on a regular basis for arthritis. I let them know I take a vitamin on a regular basis. All right, so, and that is actually part of my calculation of, quote, the medications that I take on a regular basis. Now, again, important to emphasize, just because it may exist on paper that drugs are interacting adversely with each other doesn't guarantee in you as an individual that it's going to have an effect that to me as a provider or to you as a patient that really is meaningful clinically. But you know, we just want to be aware of the potential. Now, what sort of brings the idea to mind that, yeah, this particular supplement or this particular herbal preparation or this particular prescription item may be the real McCoy and may be causing more harm than it's doing good. All right, things are getting worse. Right? So, you know, you're on an arthritis medication and you get prescribed another arthritis medication and suddenly your symptoms just flare, they're getting 10 times worse. Well, maybe that is a drug-drug interaction, all right? And oftentimes this occurs too when somebody's being prescribed a medication for a new condition. You know, and particularly in women, we would see women who have problems with, you know, irritable bladder or they lose control of their bladder at times. And they get prescribed medications for such. Well, we now begun to recognize that sometimes that causes problems with memory, right? So you're prescribing medication for one potential positive effect, but it ends up actually causing a negative effect upon a different area of the body. So, you know, the thing to think of is really, you know, things just don't seem right. They're on a bunch of medications to begin with, all right? Could this potentially be an effect of the medications? Could be an individual medication causing a side effect which has not been recognized, or could it be a combination of medications which are interacting adversely? So you at least want to raise that possibility. And one of the things I learned in my career as a physician as I got older in particular is when I saw somebody coming to see me as a new patient and they're 82 years old and they're on a dozen different medications, is to go through that list very, very carefully and say, are these really necessary? All right. Is there potential that some of these may be causing more harm than they're doing good? Now, we as providers and your pharmacist also as the person who gives you medications are aware of this. All right, they're very much aware. This is all over the literature that we read, that there is a potential for adverse drug reactions, in particular the more medications that you take. All right. And in fact, we are given alerts, especially through, our electronic medical systems that we read. Now, the problems can occur because, again, they may not be aware of, quote, which medications that you're actually taking. If you haven't reported that supplement or that herbal preparation or the over-the-counter ibuprofen, all right? So if you can't see it, you can't necessarily shoot at it, all right? Now, this tends to be a problem in people who are seeing multiple physicians. That if you're seeing a cardiologist, he may have you on 3 or 4 different medications for your heart failure, all right? But he's not aware that you're necessarily taking medications for your diabetes and your thyroid and whatever, how those medications may interact. We tend to think that computer systems are so smart that they can talk to each other. Well, they don't. And that's partly because of legislation, partly because of restrictions in exchanging healthcare information. But if you're going to Lewis Gale and you're also going to Augusta Health, rarely do those two systems communicate with each other in terms of what your medication list is in one facility versus what your medication list is at another facility. So that's where, again, where I think we need to be interactive and thrust that information out in front of the people that we're seeing, to make sure they've got it into their system. And last but not least, we're human. There's so much information that's coming in, we can't always remember, that this drug causes the potential for a drug-drug interaction, 1% of the time and in the wrong individual. Now, again, we mentioned that there are alerts. There are certain medications in particular that are relatively notorious for causing interactions between one drug and another. And many systems now have built into them where they'll flag a medication, especially if you prescribe another medication on top of it and say, well, be on the lookout. This could cause problems. Part of the problem is that these things pop up so commonly on the provider's screen that you tend to sort of shrug it off. It's like, this is baloney, But sometimes it's the real McCoy. All right, so that's why I think patients and families are very key in saying, doc, I'm not sure, all right, I'm having problems. Could this possibly be related to some negative effect from medications that I'm taking? So how do you approach this, all right? The person would come in and pound their hands on my desk and say, that medication you prescribed is lousy and it's killing grandpa, all right? I don't want any more of this, all right? We tend to get a little bit defensive about that. So I think if you approach things gently and say, I would like to raise the possibility that this medication may be causing a potential adverse effect in my loved one or myself. And how do we go about approaching this and saying, this is the real McCoy or is it not, right? And we also have to recognize that, there's certain medications that you absolutely have to take. It's there. If you're a terrible diabetic, if you stop your insulin, well, you're probably going to die. All right. If you have terrible congestive heart failure and you stop those 3 or 4 medications that you're on for, well, the pump ain't going to work as well. You're going to get in trouble and you could conceivably die as a consequence of it. So there may be a bottom line portion of those medications you take on a daily basis that you just can't get rid of. All right. Or would be very unwise to get rid of. Now, the worst thing you could conceivably do is to stop a medication on your own, without alerting your providers. But many times how I would approach this, if somebody came in or a family member came in and said, I'm worried about whether or not this drug is making grandpa worse, is to suggest, well, let's go through this, or let's think about this. What medications was he or she on 2 or 3 years ago? Were they doing okay at that point in time? What's been added on in the last 2 or 3 years? What happened after that addition? And in particular, what may have been added on over the course of the last 6 to 12 months. So sometimes it's just a process of elimination to say, this is more or less likely to be causing a problem. And then we also can, utilize some of these rating scales and talk about which medications are considered to be most risky or less risky to begin with. But ultimately, all right, it just gets to the point where you say, I can't be sure. I don't really know if this is, mom's getting old. This is really related to medications. The disease is getting old. And sometimes what you have to do is then just cautiously, emphasis cautiously, stop a medication. And many times within 3, 4, 5 days, you're going to be able to say, yeah, this is related to what you were observing. Grandma was getting worse. The medication was probably playing a role, or it probably is not. All right, so sometimes just a short period will be enough to suffice, but there are also some medications that may take weeks, if not months, to completely get out of your system. All right. So again, it just takes a little bit of bargaining sometimes to be able to go down that list of medications and really separate the wheat from the chaff. And sometimes I would have somebody with, 6, 8 different medications. And over a course of 2, 3 month period of time, sometimes we would eliminate one medication after another, all right, adding, subtracting, to try and figure out which medication may or may not be playing a role in what's going on. Now, sort of as we get towards the finality here, right, recognize that modern day medications are really carefully looked at before they are released onto the market. And I think for the vast majority of things, the benefits far, far outweigh the harm. So don't close the door to the potential that medications may be very, very beneficial for you. It's also difficult, and this is really more the prescriber who has to take this into consideration. Is this because the disease is simply getting worse? Okay, is your kidney function getting worse and worse over time? Is that why you feel lousy? Is that why you're nauseated? Is that why your skin itches? Or is this conceivably related to medications exacerbating the condition? Sure. Many times it's just the disease is getting worse, all right? And being fragile, being difficult to move around, bruising easily, less memory. Well, heck, for a lot of us, that's just part of getting older, all right? And you can't necessarily blame it on medications, right? So there's not a bear hiding behind the tree every time you take a medication and something changes, but have a healthy respect for what medications can and cannot do. So I'll be happy to stop here, ask questions. So don't be afraid to raise a question with your provider. Okay, all right. Don't be afraid to raise the question with your pharmacist. All right, all right. Be on the alert, especially with your loved ones, if they have new things added in and they start acting goofy, okay, or something's going south. Yes, ma'am.
On 2 of your slides, you said something about beers and STOOP
Yeah.
criteria. What is that?
These are national criteria that you used, or that talk about, they rate drugs in terms of what are the most risky medications to use, especially in geriatric populations. So for example, on that beers list would be Librium, Valium, Xanax, those types of medications in people over the age of 65, because we know that it increases the risk of cognitive problems, and increases the risk of falls, and increases the risk of disability. We've talked about bladder medications. That's on a beers list because, again, it increases the risk for cognitive problems, changes in kidney function, a whole bunch of stuff. So it's just a tool we use to help we as prescribers remember this is a medication which by itself may be seemingly benign, but if you add it on top of another 4 or 5 medications the patient's already taking to begin with, can increase the potential for an adverse drug reaction. That answer your question?
Yep.
Okay.
I have one.
Yes, ma'am.
So you see on TV these advertisements for herbal supplements.
Right.
And if you're taking medication already,
Yes.
prescription medications, what would it be best to ask your primary care if it's okay? But some of these, I don't think the primary cares really know very much about
Yeah.
either.
Yeah, you hit the nail right on the head. And my usual approach, just for me, all right, I would oftentimes say, if you want to take the glucosamine for your joints, all right, I would say, I'm not convinced that it's necessarily going to do a lot of good, but at the same time, I'm not convinced it's necessarily going to do a lot of harm. So give it a wing, see how you do, make sure everybody's aware of what you're taking, all right? But if it doesn't help, stop it, all right? And if for some reason you seem to be doing worse in any sphere, your blood pressure goes out of control, your memory's not as crisp, stop it, right? Stop
Another question.
it. Stop that, so, yeah, stop taking that supplement. Yeah, but you're asking a good question, is that even before I start to take it, yeah, I would like to bring it forward to whoever you consider to be your main doctor and say, is this okay to take? Or at the very least, check with your pharmacist and say, is this okay to take? The problem we ran into more than anything was that if 1 is good, 2 is better, and 12 is great. So 1 or 2 may be very unlikely to cause any problems, but 12 or whatever probably is.
All right, so there's two. One is FDA question,
Okay,
which are better asking up to you, just look at it too. FDA, some of these supplements, and see a lot of things you can go online and
Yep.
read about
Yep.
too. And some of them say not FDA approved
Yes.
yet, or
Yeah.
or approved.
Or printers like
So-
this. and you
So
can't
how
read
do you know?
Yep.
What to do? And I don't know if all pharmacists in my PCP is up on all this stuff.
Yeah.
So,
they're probably
Yes.
not.
right, so, and maybe a friend said, well, I'm taking this and doing something.
Yeah.
And that's a testimonial
Yep.
to make me think, well, maybe I should try it.
Yeah.
And that's my concern, is I
Yeah.
don't want to mess up what I'm already
Yeah,
doing.
the general rule of thumb, if it sounds too good to be true, it's probably not true. All right. And it's crazy in that prescription medications in this country, again, they go through this huge regulatory oversight before they're launched, especially the first few years after the launch, and even for 10, 15, 20 years after their launch. So they really are under a lot of scrutiny in terms of benefits versus risk. But if it's herbal or it's vitamin, it's considered to be natural, there's virtually no oversight on these things, right? So they're not really reviewed by the Food and Drug Administration unless it's just something that's absolutely outlandish. You know, if you lay something with arsenic, well, it ain't good.
Does that make them less liable because it's not
Yes.
say
Yes.
FDA approved?
Because they always have an infant, all right? If you have problems, consult your doctor. Yeah. All right, so I have a cautious skepticism for many of the over-the-counter things, unless it was originally a prescription drug and it's been used so commonly and for so long and has such a long track record of safety that it's now been released for over-the-counter use, Claritin for your sniffles or ibuprofen for your sore joints, all right? But, you know, if it's somebody that wants to prescribe something that really has not had the test of time, but quote, it's not considered to be a prescription medication and therefore is not really FDA regulated, I'm going to be careful about it. All right. I always talk with patients, you don't want to be the first in a series of 10 people to take anything, okay? Because you really don't know the safety of whatever that is until it's probably been used in tens of thousands of individuals. So unless the situation is really desperate, right, I would rarely get on a new non-FDA regulated over-the-counter agent, all right, on my.
It's like my sister, she'll see an ad on TV that I can't remember the name of it. This is gonna help you improve your memory.
Mhm.
So then she'll tell me, she says, you don't even know such and such. I said, yeah, you don't take it.
Yeah, that's one thing that really gets in my craw because there's not a lick of proof, okay, that any supplement really has a positive impact upon memory, all right? Now, do they necessarily do any harm? Probably not, okay? But I have somebody I know personally, all right, who's taking a supplement and is not on a prescription drug, which probably would help he or she, all right? So sometimes it also defers really getting in and taking something which has a proven track record a proven track record of low risk that may be beneficial. So sometimes it just deters the whole process. But this is just, again, where you hopefully have got a good relationship with whoever your regular provider is so that you can discuss these kinds of things openly. Yes, sir.
Well, in that regard, I'm on a blood thinner
Yes, sir.
and I'm gonna be on it for, I don't know, maybe forever.
Until the last nail's in the coffin.
So thank you for that information. But
And she may provide.
just got the hand.
Oh,
No, my question was,
Yes, sir.
if you're ever able to get off.
Yeah.
Something like that.
Yeah.
I mean, something I read says you need to be very careful about it or be tested or whatever. Is there a kind of a guessing game involved with that or?
You mean if you had to start the medication again?
No.
If you stop?
Stop it.
Yeah, and let's use the particular instance of blood thinners. Most of the time when you end up on a blood thinner, whatever the reason is, it's because of a blood clot somewhere, right? Or you're at risk for a blood clot. And typically you're going to be on it for an absolute minimum of 3 to 6 months, right? But there are certain situations, for example, in which there's a persistent blood clot, or you have something like, quote, atrial fibrillation, which puts you at risk for blood clots forming in the heart, which go to the brain, in which you may well end up on medication for the long term. So more times than not, in particular on blood thinners, you're going to stay on it long term. All right. Now, for example, if you were involved in a car wreck and you break your leg, and you're stuck in a hospital bed for 3 weeks and you require surgery and you develop a blood clot in and around the time of the injury, you recover from the injury, you regain your mobility, your leg's doing okay, you've demonstrated after 3 months that the blood clot is going away, probably can stop it.
Take a medication for years, and all of a sudden it's not seeming like it's doing
Yeah.
what it should be
Yeah.
doing. Is that because of the liver processing it, or can you somehow, I don't want to say build up an immunity, but somehow?
Yeah. More times than not, it's just birthdays. More times than not, it's just birthdays. But, sometimes, your system is just not metabolizing the medication like it used to or whatever. So sometimes you might be a change in the dose or adding something on top of that medication or even substituting a medication. But again, that's just part of that give and take with your provider that you have to go through. Because, it all ultimately boils down to this particular patient with this particular set of circumstances on this particular set of medications, and then I'll make my decision what I'm going to do or not do.
And it sounds like it's trial and error.
Yep.
And,
Yep. Yep.
and you're the guinea pig.
Yeah, but don't be the one that's doing the trial and error by yourself.
Right.
Have somebody else involved in the process. Yeah, but it is trial and error a lot of times. So that's what I'd sit down and say, if this is potentially is a 1 in 1,000 risk of this particular, bad side effect or bad drug reaction, and you happen to be that one, well, it's 100% for you. Okay. All right. So sometimes you just do not know short of a process of elimination. But more times than not, even though I thought this wasn't going to make any difference, if I stopped this particular medication, I wanted to prove it to the patient and the family that, yeah, I don't think this is the real McCoy. I think it's birthdays. Yes, ma'am.
Just a suggestion, will not solve the problem of reporting supplements and herbal preparations and stuff. But for anyone who has Medicare benefits,
Yeah.
if you establish an account at medicare.gov.
Yeah.
You can print out all the drugs that you received by prescription in the last 12 months.
Yeah.
And that is very helpful, especially if you're seeing more than one physician, you're seeing some specialists.
Yeah.
Because we're right now in the middle of doing open enrollment for drug plans, and we're very clear about, please tell us all of your drugs.
Yeah.
And then we go and check, and there's 3 more. Oh, yeah, that's what the vascular surgeon gave me, or that's what the
Yeah.
neurologist gave me, or the cardiologist.
Yeah, we
So
all.
Medicare has access to that information.
Yes, they do.
What drugs you're taking.
Yes, but they don't always share it. okay?
Yeah.
You know, unless you request it. So we all walk around with a computer on our side, you know, you could store all this information in there. So the very least, right, is have it on your phone. Part of the reason I encourage people to have a printed list of your medications with you 24/7. You get cracked in the head, you're in an accident, you know, you can't relate information to somebody. Well, one of the things they're going to do is they're going to dig through your wallet, find out, you know, who you are, where your loved ones are, and hopefully they'll stumble upon your list of medications in that circumstance. So even though I think computers are great, right, they don't always relay information. All right. Just like, it'd be like going out in the field, Gordon, with a GPS system and no compass, okay? Yeah, you know, the GPS goes sour because your batteries die, but a compass never does.
And you can establish a secure account to
Yeah.
access your own Medicare records, and
Yeah.
that will show every single prescription you've had filled in the last 12
Yeah.
months that you used your Medicare drug plan for.
Where is that located on?
Medicare.gov,
I know that, but.
and then up at the very top, it says log in. Click on log in,
Yeah.
and below username and password, it says open an account or establish an account.
Yeah.
Go
Where do you
there.
find that list is what I'm looking for.
Oh,
Sorry.
then, once you're in, you have logged into your account, one of your options, and they're in big squares, is print my drug list.
Okay,
Yeah.
thank you. That's what it's-
And what will be in there is anything that you have put in. And then it says add recently prescribed drugs.
Yeah.
And that will update it to whatever has been received in the last 12 months.
So the two most important things that I think you can store on your phone or on your computer that you might need in an emergency kind of situation, or if you're getting care in an unfamiliar environment, are your medications, again, including supplements, herbal preparations, over-the-counter agents, and advanced care directives.
Yeah.
And have both of those on my phone. Okay,
Oh,
I don't have that on.
wow.
and they do have means now similar for advanced care directives, where you can not only store it on your device, but then it can be shared. Okay, with other
So
settings.
if you got a road ID for that, it would cost you $500 to put all that stuff on it.
Not a bad idea. Okay, not a bad idea.
Does your physician, when they prescribe something, do they put it on Medicare? I
No,
mean, if they.
it's when you go to the
You have to do
drugstore.
that all this
What,
yourself.
you go to the drugstore, you get a prescription filled,
Right.
it's billed through your Medicare drug plan.
Mhm.
It automatically goes into Medicare's
Oh.
database with name and strength. It does not show frequency, so it doesn't show whether you're taking it 3 times a day or once, but,
So we.
It's because Medicare is paying for it.
right,
Does it show the amount of the drug, like the milligrams?
yes.
They show you all.
However, we have TRICARE for life, so we have Express
Yeah.
Scripts. That's a little different than Medicare.
I would
drug
say, look at Express Scripts website and see whether or not you can establish an account.
plan.
And then you can do a printout of activity, what they filled.
Yeah, most electronic medical record systems for medical related issues or medication related issues are sophisticated enough now that you should be able to separate out, you know, if you navigate it correctly and go through enough clicks, what are your medications, you know, which ones and which doses, how often do you take them, et cetera, when they were prescribed, and that information should be retrievable. If it's not, I'd bug somebody and say, why isn't this information out there? If not, it should be available through whichever healthcare system. So not just your insurance, but your healthcare system should have that information pretty readily available. Okay. All right, good questions. All right. Thank you very much. Appreciate it.
Thank you very much.
Thank you.